Okay, let's unpack this. We're diving deep today, specifically into aphasia.
Sounds good.
We've got a stack of notes right here,
Oh.
the kind that are perfect for tackling revision, maybe for an exam, or just really getting a solid understanding.
Absolutely. Revision notes are great source material.
So our mission in this deep dive, really, is to take these notes, zoom in on what's crucial, connect the dots, and make sure it all sticks.
Kind of guide you through it.
Exactly.
Yeah.
We'll pull out the high-yield nuggets about aphasia, what it is, why it happens, how it shows up, and, importantly, what's done to help.
And for a topic like aphasia, understanding the why behind it all, why specific brain areas matter, why communication breaks down in certain ways, that's absolutely key.
Yeah.
It's not just about memorizing terms. It's about grasping the impact, seeing how all these pieces fit together.
Couldn't agree more. So let's jump right in. At its core, what is aphasia? These notes start with the definition.
Right. It's defined as a communication disorder.
Affecting language, understanding, and expression.
Precisely. And the fundamental cause, as the notes say, is brain damage. Often, this damage is in the left hemisphere.
Which is the main language side for most people.
That's right. And this isn't just about speaking difficulties. It hits everything: speaking, listening, reading, writing.
Wow.
Yeah. And that, of course, profoundly affects communication skills and, well, overall quality of life.
Okay, so here's where it gets really interesting looking at these notes. Aphasia isn't just one single thing, is it?
Not at all.
The damage can be in different spots, leading to totally different presentations. These notes break down 4 key types.
Yeah, and exploring those differences really tells you a lot about how the brain handles language.
Let's do that. First up, Wernicke's aphasia, sometimes called receptive aphasia.
That's the one.
The notes point to damage in the superior temporal gyrus. Where's that, roughly? And what's its job?
Okay, so think temporal lobe, kind of behind your ear. The superior temporal gyrus is in the upper part there.
Got it.
It's supplied by the inferior branch of the left middle cerebral artery, the MCA. And it's critical because it handles incoming language, understanding what you hear, what you read.
So it decodes the language before you even think about replying?
Exactly. It's that processing stage. So when that area is damaged, comprehension is significantly impaired.
But the notes say speech is fluent but incoherent. How does that work?
Well, the motor areas for actually producing speech aren't directly hit. So the person can talk quite fluently, normal rhythm, intonation, but the content is off. You get what's called word salad, or neologisms, made-up words, because they can't access the right words properly. And often they aren't aware that what they're saying doesn't make sense or that they aren't understanding you. It's quite disorienting.
Okay, so Wernicke's understanding is the main problem, leading to fluent but jumbled speech. Let's contrast that with Broca's aphasia, the expressive type. Where's the damage here?
Broca's area is different. It's in the inferior frontal gyrus, so more towards the front of the brain, lower down, supplied by the superior branch of the left MCA.
And its job is?
Production.
Great.
Speech production. Taking your thoughts and turning them into spoken words or written words. The output side.
And the notes say their speech is non-fluent.
Exactly. Because that production system is damaged. Speech becomes really effortful, halting, labored, often just short phrases, grammatically simple, sometimes called telegraphic.
Like sending a telegram, just the key words?
Sort of, yeah. Repetition is also really hard for them. But, and this is the key difference from Wernicke's, their comprehension is usually pretty good.
Ah, so they understand you. Okay.
Generally, yes. They know what they want to say. The words are often there in their head, but physically getting them out smoothly is the struggle.
Right. That must be incredibly frustrating. Okay, so we have Wernicke's, understanding impaired, fluent, but garbled speech, and Broca's understanding, okay, non-fluent speech. What about conduction aphasia? The name sounds like a connection problem.
Spot on. It is. The notes highlight this is usually from damage, often a stroke, affecting the arcuate fasciculus.
The arcuate fasciculus, that's the pathway connecting them.
Exactly. Think of it as the main highway connecting Wernicke's area comprehension and Broca's area production.
So if the highway's out,
information flow gets disrupted. What's really characteristic here is that comprehension is generally good, and speech can be fairly fluent.
But
ask them to repeat something right after they hear it. That's where the breakdown is clear. That direct Wernicke's to Broca's link for repetition is damaged.
And the notes say they're often aware of their mistakes.
Yes, unlike Wernicke's typically. They often recognize they've made an error when trying to repeat, which, as you said, adds another layer of frustration.
Makes sense. Okay, last one listed, global aphasia. Sounds extensive.
It is. Global aphasia means a large lesion, a big area of damage that hits both Wernicke's and Broca's areas, and often the connections between them, too.
So severe problems with both understanding and speaking.
Exactly. Severe impairments across the board, expression and reception. Communication is extremely difficult.
Is any communication possible?
It's very limited verbally. But, as the notes mention, sometimes gestures, facial expressions, maybe some nonverbal cues can be used for very basic communication.
Okay. So that breakdown of types really drives home how specific brain locations link to specific language problems. Location really matters.
Absolutely. That's a massive takeaway.
Which leads us neatly to the next question. What actually causes this brain damage? The notes list the main culprits.
Yeah, the number one cause, the one highlighted first, is stroke, particularly ischemic stroke, a blockage cutting off blood flow.
But it's not only stroke.
No, definitely not. The notes also list traumatic brain injury, or TBI, brain tumors if they press on or grow into those language areas, brain infections like encephalitis, and also degenerative brain disorders.
Like Alzheimer's, the notes mention that.
All right, Alzheimer's is given as an example, often leading to what's called primary progressive aphasia, or PPA, where language gets worse over time. And other neurological conditions, like MS, multiple sclerosis, can sometimes be involved too.
Okay, so given those causes, who's most at risk?
Well, the biggest risk factor is just having any condition that could cause brain injury in that language-dominant hemisphere.
So since stroke is the main cause.
Exactly. Anything that increases your stroke risk indirectly increases your aphasia risk. So the notes list things like high blood pressure, smoking, diabetes, high cholesterol, heart disease. Those are major factors.
And other risks.
They depend on the other causes, right? Risk of head injury for TBI, maybe age for degenerative conditions like Alzheimer's. It varies.
Let's go a bit deeper into the how, the pathophysiology. How does hitting these brain areas actually stop someone finding words or understanding?
It boils down to disrupting the incredibly complex neural networks we use for language. We've talked about the key hubs, frontal, temporal, parietal lobes in the left hemisphere usually. But it's really about the connections, the pathways between them.
Like a communication network in the brain.
Precisely. A network that lets information flow smoothly for speaking, listening, reading, writing. When damage occurs, it's like cutting wires in that network.
And the specific problem depends on which wires are cut.
Exactly. Damage Wernicke's, you disrupt the meaning decoding part. Damage Broca's, you disrupt the speech planning part. Damage the connection, you disrupt the flow between them. The bigger the damage, the more functions are affected, like in global aphasia.
And the notes mention neuroplasticity here too.
Yes, which is crucial. The brain's amazing ability to reorganize, to adapt. Undamaged areas might take over functions, or new pathways can form or strengthen. That's the basis for recovery and rehabilitation.
That's a really important point, the potential for adaptation. But before we get to recovery, we need to know what aphasia isn't. What else can look similar? The differential diagnosis.
That's a key question for clinicians, yeah. Aphasia is about language processing. Other things affect communication differently. The notes list some important ones.
Like primary progressive aphasia.
Right. PPA is a type of aphasia, but its cause is different neurodegeneration, and its onset is gradual, not usually sudden like post-stroke aphasia. So it's distinguished that way.
What else?
Then there's dysarthria. That's a motor speech disorder. Language itself is fine, but the muscles used for speech are weak or uncoordinated, so speech sounds slurred or imprecise.
So the message is okay, but the delivery is fuzzy.
Kind of, yeah. And then there's apraxia of speech. Again, language is okay, muscles might be strong, but the brain has trouble planning and sequencing the movements needed for speech. Like the signals get mixed up.
Okay. Any others?
The notes mention global developmental language disorder that's seen in children, an issue with language development from early on, not acquired later, like most aphasia, and psychiatric conditions. Things like schizophrenia or severe depression can affect communication patterns, but it's not a primary language disorder in the same sense as aphasia.
So it takes careful assessment to tell these apart.
Definitely. Usually by a speech-language pathologist, maybe a neurologist, using specific tests.
Right. Speaking of which, how common is aphasia? The notes give some UK figures.
Yeah, exact. Prevalence is tricky, but the link to stroke gives us a good idea of the scale. The notes say over 100,000 strokes happen each year in the UK. That's a huge number.
And aphasia effects?
About a third of stroke survivors, according to these notes. Roughly 1 in 3. So that really underscores how significant aphasia is just within that stroke population alone.
Wow. Okay, zooming back out to the person experiencing it. How does aphasia actually look clinically? What symptoms might you notice?
Well, as we've seen with the types, it varies a lot. Depends on the area damaged, how severe it is. But the common threads listed in the notes include difficulty finding words.
Anomia.
That's the term. Yes, anomia. Also, trouble understanding spoken or written language receptive problems, difficulty forming sentences, speaking fluently expressive problems, and issues with reading, alexia, or writing, agraphia.
And it's not just the mechanics of language, right? The notes mention emotional impact.
Absolutely crucial point. Imagine knowing what you want to say but not being able to, or hearing noise but not meaning. It leads to immense frustration, anxiety.
Social withdrawal.
Very common. And sometimes depression. It's a profound human challenge, not just a technical language problem.
So if someone shows these signs, what investigations get done to confirm it and find the cause?
Well, the process usually starts with that detailed language assessment we mentioned. A speech-language pathologist or neurologist uses standardized tests.
What they test?
Everything. Comprehension, fluency, naming things, repeating phrases, reading, writing. That helps nail down the specific and severity of the aphasia.
But that doesn't tell you why it happened.
Exactly. That's where imaging comes in. Brain scans, CT or MRI, are essential to see the brain structure, find the stroke or the tumor or whatever the underlying cause is.
Any other tests?
Sometimes, yeah. Depending on what the clinician suspects, maybe blood tests, perhaps an EEG to check for seizures, but the core is language assessment and imaging.
Okay, diagnosis confirmed. What's the plan? How is aphasia managed, particularly thinking about the UK system?
Management is typically multidisciplinary, as the notes say, but the speech-language therapist, the SLT, usually leads the communication side.
And the goals are?
Really practical. Improve language skills where possible, definitely enhance functional communication for everyday life, and provide coping strategies for the person and their family.
What sort of techniques are used?
All sorts. Specific language exercises targeting weak areas, communication strategies, maybe using gestures, drawing, writing keywords, augmentative and alternative communication, AAC.
Like communication boards or apps?
Yeah, could be simple picture boards, could be sophisticated apps or devices. Technology-assisted aids are increasingly used.
And you also have to treat the underlying cause, right?
Absolutely. Managing the stroke, the tumor, whatever it was, is vital. And the notes also stress the psychosocial support groups, counseling. Aphasia affects the whole family, so that emotional and social support is critical.
What about recovery? What's the outlook, the prognosis?
It varies hugely. The notes list the key factors.
Hmm.
The cause, how big and where the damage was, the person's age, their general health, how much therapy they get.
So some people recover a lot, others less so.
Yes. Recovery can range from pretty significant improvement, sometimes even near complete recovery, to more limited gains. Neuroplasticity is the mechanism, but its extent varies.
Is it a quick process?
Rarely. It's often a long haul, needing ongoing rehabilitation and support. If significant aphasia persists, the focus shifts more towards long-term management, maximizing function and quality of life despite the deficit.
Finally, the notes mention complications. What are the potential negative impacts of living with aphasia?
Well, the impact on quality of life and daily function is massive. The communication barrier itself leads directly to frustration, social isolation, difficulties in relationships.
Simple things become hard.
Exactly. Reading, writing, understanding instructions, holding a conversation all become challenging. It can seriously affect work, education, just participating in society.
And the emotional side again.
Definitely. The notes correctly point out the significant emotional toll. Increased risk of depression, anxiety, low self-esteem. It's tough. Which is why that ongoing support, therapy, and rehab are so crucial to minimize these impacts and improve well-being.
Wow. Okay, that was a really thorough walkthrough of these aphasia notes. We've gone from, tiny brain areas right up to the huge impact on someone's life.
Yeah, we've tried to pull out the key bits, structure it logically, connect the dots between the anatomy, the causes, the effects, hopefully making it really high yield for revision.
Hopefully breaking it down like that, seeing how it all links together, gives you that aha moment, that clearer picture of what aphasia really involves.
And here's something to think about, maybe a provocative thought. If our ability to communicate, to connect with others, is so tied to these specific, quite delicate parts of our brain, how does learning about aphasia change how we view language itself? Is it just a tool we use, or is it actually a really vulnerable biological process, something we maybe take for granted?
That's a great point. Okay, so if you found this deep dive useful for understanding aphasia or for your revision, there are more resources available. For really comprehensive revision materials covering loads of topics, you can check out PassTheMSRA.com.
Great resource.
And if you want to test yourself with some free practice questions, see how much has sunk in, head over to freemsra.com.
Always good to test yourself.
Definitely. Keep diving deep.